In the US, a ROCK inhibitor received approval for treatment of therapy-refractory chronic GvHD. This ROCK inhibitor is not available currently in Europe because the company that has investigated this agent has just recently been bought by another company. So we don't actually know when in Europe we will have this ROCK inhibitor available. And what is too bad, because the data seem to be quite promising. We also hope that with regard to this ROCK inhibitor, that there will be a phase 3 study planned, because so far we only have phase 2 study data. We do have data that has been presented at this year's EHA meeting about the use of Ibrutinib in a randomized multi-center control study as first-line treatment for patients with chronic GvHD, where Ibrutinib was not better compared to conventional treatment with steroids at 1 milligram per kilogram body weight and calcineurin inhibitors. This data will hopefully be published also pretty soon. And Ibrutinib so far has received only approval in the US for treatment of steroid-refractory chronic GvHD patients. I don't know whether the company has any interest in seeking EMA approval. And then some other recent activities, of course, have been the NIH consensus meeting last November, where I was fortunate to participate in the working group on therapy and study designs. We were able to publish all the summary documents of the different working groups in just during the last months. So, for example, for new developments in therapy of chronic GvHD for first-line treatment, we strongly emphasize there to have studies without steroids. That means if you have a promising new or targeted agent with preclinical data that supports the use in chronic GvHD, we would emphasize to have a clinical study where this agent is investigated without steroids under strict conditions. That means you have to have centers that have study experience, that are able to monitor patients closely, so that in case of progression of chronic GvHD, steroids can be started. And together with this steroid-free treatment, another important part is to investigate the biomarkers at study enrollment, but also in between, to get more insight into the pathophysiology of chronic GvHD and also the mechanisms of action of the new treatments. And then after 3 and 6 months to do a clinical response assessment. And also we would then have the biomarker data available and could then analyze different phenotypes of chronic GvHD patients separately. So, for example, the inflammatory or the fibrotic ones, or the ones who have immune dysregulation, and then get more information how to continue from there. To me, this is a very promising strategy because it would allow to increase our knowledge on the pathophysiology of the different phenotypes of chronic GvHD, but also we would be able to have more information on the mechanisms of action, on biomarkers that could be used for diagnostic or prognostic purposes. So these sort of studies would have a high potential to move the field forward.